Looks like it's having a wee think about whether to go live or not. And as soon as I can see us there, I'm going to get chatting. Okay, it looks like we could be live. Let me just quickly check that. And then I'm going to share us over into the bigger group. Come on, slow thing. All right, here we go. Like we could be live. Let me just quickly check that. Okay, so I'm going to share this. Sorry, Simon, it's all fun and games on Facebook. Okay, where are we? Okay, I don't know how I'm going to share this because it's sort of stuck there. Let's see, hold on. That's good. We can just build up some watches while we're trying to share it.
Yeah, the technicalities of getting these things to work, it's not always simple.
It's a bit nerve-wracking. Okay, where are we? I can see something there. I might just have to get one of the girls to share it for me. Girls! Okay. All right, I'm just going to ask them to share, please. All right, well, let's get started and let me get some questions out for you. First of all, thank you so much for coming to talk to us. We are a group of, I guess, a diverse lot of women in the 30 plus age group, and collectively in all of the different groups there's about 45,000 of us. So obviously we'd have all of our own different opinions and ideas on things. So all I wanted to do was just, you know, ask an expert some good questions and get some answers. So thank you so much, Simon Thornley, Dr. Simon Thornley, epidemiologist, for coming to talk to us today. Can you just tell us a little bit more about who you are and what you do so that the girls can hear your credentials?
Sure. Well, thanks for having me, Natalia. I'm a senior lecturer at the University of Auckland in public health. I trained in medicine, initially did some work in the hospital as a med-reg, and then kind of found public health and prevention more interesting, so trained in that area, did a PhD in epidemiology, which is really just kind of medical statistics, and that's where I've been working mostly part-time on and off in the university and also in public health. Few subjects that I've championed over the years have been the health effects of sugar and the effect on metabolic health and waistlines and that sort of stuff. Also, more recently been looking at scabies, which is a little insect-like creature that lives in the skin, and been looking at the connection between having that skin rash and rheumatic fever, which is a sort of serious disease of the heart valves. So those have been, I've also was working for public health up until very recently, helping them with model infectious diseases such as measles. There was an outbreak in 2019, I think, and giving them advice on epidemiological things.
That's awesome. Well, those are some pretty flash credentials, but brighter than my credentials, but that's why I'm asking the questions and you're answering them. So I just on that, so I did actually see one of the girls say yesterday when we were asking for questions, she said that you specialise, you know, Dr. Thornley specialises in skin diseases, so, you know, what does he really know, or how can he really contribute towards the COVID conversation? So how can I console them where it comes to viruses and COVID, that you do know what you're talking about?
Well, epidemiology is really about numbers and making sense of health-related numbers. So I've been doing some, I'm not a skin specialist, I'm not a dermatologist. That's been a research area of interest for me. I've been involved in modeling and writing about various infectious diseases such as measles. And there's I don't see a reason why I shouldn't be able to speak into the COVID space. We're all learning very quickly on COVID. It's only been around for 9-10 months, so we're all learning as a medical community on this.
Diving deep and quickly, yeah. Okay, so let's just crack into some of the questions that the girls have put up here, and I'm just reading them straight from the data. Okay, so what is the data now saying about COVID? How much of a threat is it, and how does it compare to other viruses like influenza?
That's a good question. I might just try and share a screen here. Yeah, well, I think the way we usually look at the threat of viruses is looking at the deaths from COVID over the cases. So that's called a case fatality rate. And initially, when you get a new virus, often the people who are tested are just the ones in the hospital. And so you have the cases in the hospital and the deaths in the hospital. And initially, the case fatality rate was very high, about 3.4%, which compares to seasonal influenza around about 0.1 to 0.5%. But what we see with new viruses is that denominator gets bigger and bigger and bigger the more we start testing. So initially, it's just swab tests in the hospital, and then we find that there's actually cases in the community, and then we find that there's people who have antibodies, and then you may have read a little bit about people with T-cell responses to the virus. So you can see that the ratio of deaths to the number of people goes down, 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 depending on what your denominator is. And we have this increasing evidence of exposure to the virus in many more sectors of the community than we initially thought. So that 3.4% has now been dialed back to at least 0.3% based on the serology, which puts it in the range of H1N1, which was swine flu back in 2009. You can see that when you look at the crude case fatality for different countries, these are just countries, and the case fatality ratio up here, 10% in some countries like Italy, but very, very low, like 0.05% in some Asian countries such as Singapore. And we think that that's related to factors such as testing and how extensively the population has been tested. In a compact country like Singapore, it's obviously easier to test more people. And in terms of how that compares with flu, it is really hard because there's a lot of different estimates for how bad flu is. And if you look at you see here, it goes all the way from 0.01%, which is 1 in 10,000, to some estimates here of being 1 in 100. And it depends on that denominator again. And what we're seeing for COVID is around this area here, which is a little bit more than seasonal flu.
Yeah.
But not that much more.
So is it more, so is COVID a nastier strain of a flu, or is it just is it like the flu, or is it way worse than the flu?
There's about 6 different coronaviruses that affect humans. There's others that affect animals. And 2 have been particularly nasty, MERS and SARS, that you probably know about, that have hit the headlines and caused high proportions of fatalities in hospital.
Mm-hmm.
But there's also 4 others that cause what we call influenza-like illnesses. So they're not, influenza is a separate family of viruses. So these are the other 4 are the types that cause colds and flu-like illness. And we haven't really taken much notice of those. But we know actually now, in retrospect, that these viruses like NL63, which is another coronavirus, has caused major problems in rest homes. And that's where we've seen a lot of the problems with COVID. Over half of the fatalities globally have been in people who live in rest homes. So we know that these viruses, even though we kind of think of them as fairly mild, that they can really wreak havoc in elderly, frail people. And COVID seems to be behaving like these less severe coronaviruses, like NL63, like HKU1.
Yeah. So the point of so I had quite a lot of people saying things like making reference to America really quite often. Oh, look at, well, at least we're not in America. Look what Trump's done to his whole country. It's all falling apart. Everybody's dying left, right, and centre. Luckily, New Zealand's only had, whatever number of cases we've had now. How can we really, do they relate to each other at all? Like you're talking about, it's a testing thing. They've done a lot of testing. Have we done the same amount of testing? Can we even relate in New Zealand being so much better off than America based on those numbers?
Yeah, well, definitely cases are lower in New Zealand and deaths are much lower per capita in New Zealand than the States. But I think one thing you've got to realize that you don't see if you focus on the numbers is just in terms of what sort of range of ages are dying of or with COVID. And so this is some data that I've done on New Zealand, but actually this is replicated all around the world. And let me just get my little spotlight. So this is the age of COVID deaths in New Zealand, and that's the scale there, the count. So you can see most of them have occurred at within the age group of 80 to 89.
Wow.
And this in the black is the age group of deaths the year before in 2019, when we thought we had no COVID. This is just natural mortality.
Wow.
And basically, you're seeing no difference in age of death and in the pattern or what we call in epidemiology, the distribution of the age of death between people who have COVID and non-COVID. And we can actually do a formal test for whether these patterns are different, and we see a p of 0.998. So 1 is absolutely no difference, and that's as close as you get to no difference. So this doesn't tend to be shared when it's very easy to see the headlines of thousands of deaths in the US. And what we see, that's New Zealand, but we see that pattern everywhere else in the world where you look. And so this here is a similar pattern in Italy, and you see that the mode here, the most frequent age of death is 80 to 89 years. And
Wow.
so this would actually be very similar to the age distribution of deaths in Italy, I imagine, if we looked at
Really?
it just as we do with New Zealand.
So I want to ask you two questions, but one, I just noticed you said you were about to say that people who died of COVID, but you actually corrected yourself to died with COVID. So explain that to me a little bit more. Are people dying with COVID and not necessarily of COVID?
That's a good question. So you may have a slide here, maybe not. So that's a good question. I think what I saw early on was that there was a real, the story of COVID was so strong that there was a rush to attribute deaths to COVID, and particularly in Italy early on. And there was a formal review of the causes of death afterward, and I saw a government review saying only 12% of deaths, so it's about 1 in 8, actually due to the virus itself. Many people in in this age group that you see here, in the 80 to 89 year age group, are frail and have many other reasons why they might die, whether it's their cardiovascular disease or a cancer or some of those other factors. So often it's very hard for doctors, it seems fairly straightforward to attribute a cause of death from the outside, but actually when you get into the nitty-gritty, often it is difficult, and only a very small fraction of patients have had autopsies to actually determine the cause of death.
Why is that? Sorry, Dr. Thornley, why is it that they haven't done the autopsies to see?
Well, it's not a usual thing to do an autopsy. Often it's just the cause of death is kind of inferred from the illness, the last illness that the patient had, if it's expected. But often in those last few years of life, when people are, in their 80s and 90s, it's often difficult to be absolutely certain what the cause of death was, and early on I saw that there wasn't actually a good definition of a COVID death. That's been tidied up subsequently. It's got to be somebody who tests positive with a respiratory illness. But even in New Zealand, I think 5 of the deaths didn't even test positive. So there seems to have been some it's not, the definition of a COVID death is not consistent from country to country, and it sounds like there has been financial incentives in some areas, particularly the US, to label people as a COVID death.
What sort of financial incentive would that be?
Well, I think there's hospitals get reimbursed in the States according to the diagnoses that patients have. Whereas that's not such a factor here because we've got a more dominant public health system.
So based on, and I know hindsight is a marvelous thing, but based on hindsight, what we know now, was the lockdown, the level 4 lockdown, was that the right way to go about the initial influx of this, outbreak?
Well, yeah, that's a good question. I think I was behind the government's thinking early on when the rationale was to protect the hospitals and the rest homes. This morning, that it's a familiar story from I spoke to a reporter in New York who said that that was the rationale there, and that actually the hospitals they always had capacity in the hospitals, even in New York, which was one of the worst hit centers. And so, but there's been a kind of changing goalposts over the course of things. Initially, it was protecting hospitals, intensive care units, flattening the curve. I thought that was sensible. But actually, never in New Zealand during this outbreak have we had a problem with capacity in hospitals and intensive care. And then it was kind of go hard and go early, and now it's elimination with a goal of early introduction of vaccination. And then recently we had 4 cases and we went to level 3 here in Auckland. So the goalposts seem to be changing, and from the sort of theory of how epidemics work, the virus spreads, and what we know from the work of David Spiegelhalter, perhaps one of the best known statisticians in the world, is that, and looking at those statistics, is that the risk of dying for people under the age of 60 is virtually zero, close to zero. In fact, he said the extra mortality risk for people over 55 years is actually like living another 30 or 40 days during the pandemic. And for people aged, for kids 5 to 14 years, it's like an extra 2 days of risk. So it's virtually nothing. So seeing that, and then I think the big issue for me is, for most health issues, we think about the costs of what we're going to do. And actually the government economists in the Productivity Commission did this analysis. He was looking at that, considering an extra 5 days of lockdown. And he looked at the costs versus the benefits. And it sounds horrible that you sort of value life in that sort of way, but that's something that there's a whole discipline of people who do that, health economists. And so what he showed was that actually the costs outweighed the benefits. He was pretty generous in terms of the benefits, 95 to 1. I mean, there's a lot of uncertainty in terms of how much benefit that extra lockdown happened. There's been another economist, Martin Lally from Capital Financial Consultants, and usually we kind of consider it to be worthwhile to spend $45,000 per year of life, or quality adjusted life year. And he's estimated that it's about 200 times that figure, what we've spent in lockdown. So I think this paints a picture for me that we've been pretty myopically focused on COVID and haven't really considered the downsides. We've seen an extra 50,000 people go on the job seeker benefit. That's quite dramatic. That's an increase by a third.
And we know that, when you've got less money and you've got, less money for decent food and decent, just, a decent lifestyle. That's going to affect health eventually, isn't it? You won't be able to build statistics on that for years to come, I would suspect. Hey, the outcome of all of this.
Yeah, well, I think we're starting to see some interesting stuff come out of the UK, where they're actually about 10 to 20% increases in deaths from untreated usual diseases such as diabetes, cardiovascular disease, untreated cancer. So this whole focus of the health sector on COVID probably led to early deaths in other areas, and that's come out in the UK. I haven't seen similar statistics here. We know that unemployment, which is likely to be a major issue related to the lockdowns and the destruction of small businesses, leads to suicide. Here's a sort of summary of a bunch of studies, and basically it shows that mass unemployment it increases the risk of suicide by about 70%.
And I've heard a lot of that. I've heard a lot of depression, a lot of huge anxiety and worry. And I have heard about suicides, but apparently our statistics are at their lowest they've been. So I don't understand that at all, and I don't know where the statistics come from. I couldn't find any when I went to look for any online, our New Zealand suicide statistics, so I couldn't even speak into that at all. But I do, personally, I've seen the depression and the anxiety, and we've had a lot more messages even through the group, just in dire straits, not knowing how they're going to feed the kids, and just some basic things, warm clothing, not being able to pay that power bill, the rent bill, all that sort of thing. We're seeing that come in now. So I mean, statistically I can't find any information on that, but I can see it, as a facilitator of a group of this many women. I can actually see the conversations, and I'm hearing the discussions, and there's something happening. Who does our government take its directive from with regard to this? If they're not listening, are they listening to the epidemiologists? Because from what I'm hearing, it doesn't translate into what they're doing or how they're outworking this health response to COVID.
Well, there's a group of epidemiologists that are advising the government, and so they are pro-lockdown, and they are pro-elimination of the virus. Obviously our Plan B group differs from their viewpoint, and we believe that elimination is going to be difficult because, for many reasons, other coronaviruses are around. We have a lot of asymptomatic cases from overseas data, very difficult to clamp down on all those. The swab test doesn't pick up every case. It's only picks up about 7 in 10.
Wow.
The clinical syndrome, so the symptoms of COVID are not especially dramatic, unlike a disease like measles or something. It's very hard to tell from other viruses. It's likely that many of us are not susceptible or immune. One thing that I think that's been unfortunate is that New Zealand hasn't done a sero survey to look for antibodies to the virus. So if you've had the virus, then your body mounts a response to that. And you can see that many, many more people have had the virus than just from the swab tests alone. So there's a recent Australian study.
What's the word again?
Sero survey.
Sero survey. So explain that a little bit better. That's
well, if we go back to swine flu days, I don't know if you remember the swine flu epidemic in 2009. It was sort of a little bit like COVID, but not as dramatic in terms of response. But there was similarly, initially fears of a very high mortality. We were trying in public health to stamp it out. We're dishing out lots of Tamiflu, waiting for a vaccine. But then we looked for antibodies in the population, and we found that actually a third of New Zealand had the virus, and we hadn't actually known about it.
Wow. That's amazing.
So, and that after that came out, the whole sort of clamour to do all this stuff died out, and I thought my response when this started to come along was that the first thing we've got to do is have a look at antibodies in the community, and just, there's so much uncertainty in terms of how many people have already seen the virus. And actually, instead of that, what I noticed was the government had banned the use of antibody tests.
Why would they do that? I don't understand. Why would they do that?
Well, I can sort of see initially there was worries about the accuracy of the tests, and there was a lot of tests coming out of China that were a bit questionable in terms of their accuracy. So people may sort of have a positive test, be falsely reassured that they've had the virus. But now we see the big manufacturers that supply the lab equipment for the government laboratories, in the hospital. They've made tests which are, we have measures of accuracy. We call them sensitivity, specificity, and they're comparable to other antibody tests. So I can't see a good reason for why we're not using them in New Zealand to give us a bigger picture of how far and wide the infection is spread. It's even useful in terms of, with the government's current approach, to get the antibody test so they know, chains of transmission of the virus in terms of who's been exposed and who's
Yeah.
got a likely contact.
It doesn't make sense to me that they wouldn't even now, pursue that. But so if you have the antibodies, does that by and large protect you from having the virus? Now, or can you get it again?
Well, there's questions about that. There's some epidemiological evidence that it does protect. There was a bunch of people who went out on a fishing boat and they were tested for COVID beforehand with antibodies, and it was only pretty much the whole boat got COVID, except for the people who had the antibodies. So that's pretty strong epidemiological evidence that the antibodies are useful and are protective. There was questions early on as to how important the antibodies were and whether they did confer protection and how long the protection lasted.
So with coronavirus, just say so I have heard that you can have the virus and be so minimal in your symptoms that you wouldn't know you had it. And if you had been that minimal, you would have antibodies, but would that protect you then from a sort of larger, more vicious strain, such as the one I guess we're supposed to be seeing now?
Well, there's certainly immunologists, and immunology is not my specialty, but I've seen evidence that immunologists are saying there's cross-reactivity in terms of immune response from other coronaviruses. So these, things like NL63, HKU1. So they are likely to lead to cross-immunity to COVID. And so probably many of us are protected from having been exposed to those other viruses than we're previously aware of. And yeah, so there has been a number of cases of individuals who seem to have had a positive COVID swab test twice, which is raising the possibility of the antibodies are not as effective as previously, but that's, an absolute drop in the ocean. It's one or two cases among many, many thousands of positive tests.
Yeah. So, not to minimize this, COVID for people who are sort of immunocompromised or susceptible, or, so I've heard, parents with children who have lung diseases and, those sorts of things. What what's a sensible way to protect those people?
Well, yeah, that's a good question. I think there's, I think the sorts of things we've been advocating for are, sensible social distancing kind of things, particularly when there's evidence that the virus is circulating for people who have chronic conditions. But for most of us, our risk from the virus is extremely low. So I don't see a good reason to shut down the country or close schools. Obviously, improving host health, I think, is worth looking into, and there's some evidence that low vitamin D levels are important. And also, we know that people with diabetes, blood pressure, overweight, and obesity are affected. And much of my work has been linking sugar and refined starch intake with those things. So I think it's a good opportunity to improve your diet. But for most of us, the risks are very low. So I can understand certainly for people with chronic conditions wanting to isolate. I think understanding our greater understanding of our level of immunity would be really useful information for patients or people who have, like you say, kids with chronic conditions, because many of us are immune, then the risk of getting the virus is, is very, very low. So then, vulnerable people would be able to circulate with more confidence. But yeah, so the vast majority of fatalities have been in rest homes and in hospitals. So we think that's really where the focus should be. We know, sorry?
On our vulnerable.
Yeah, we know some things are definitely should be avoided that other countries have done. And they've actually sent COVID positive cases to rest homes. And I think New Zealand has done very well in terms of segregating in healthcare facilities possible COVID positive patients with non-COVID patients. And that's been useful in terms of reducing spread within hospitals and within rest homes, and it's generally where the disasters have happened overseas and even in New Zealand.
Interesting. So let's just backtrack a little bit to the immunity thing, and I just wanted to ask you, with regard to all of this face masking and hand sanitizing and all this sort of stuff that we're doing to debug ourselves, is this going to have repercussions down the track when we're all so sanitized that we take off our masks and we stop sanitizing and then we get a bug and then our immunities don't know what on earth to do with it? How is it going to affect us down the track?
Yeah, that's a good question. I think I don't. My personal belief is that the masks are not particularly effective. Early on in the saga, we actually, the official advice was that masks weren't very useful.
Yeah.
And they're only really useful in a healthcare setting in very enclosed spaces. And now we seem to have flip-flopped and said masks are really useful. But looking at the trial evidence where they tried to prevent the spread of influenza within homes with masks, the trials were disappointing. And trials are only done if people really think they're going to make a difference. And so there's been a bunch that are disappointing. So yeah, the mask thing, I don't think it's particularly important. I can kind of understand the government's use of it in public transport. Aeroplanes, for example, were very confined spaces. And I have seen some observational studies which support their use. The hand sanitizer, well, it does have some theoretical benefits. I must say I use it fairly sparingly just because I'm worried about the effects on drying my skin. And, I think just usual good hand hygiene is the best. Washing hands underwater with a bit of soap and using, giving them a good wash with 10, 15 seconds, bit of friction, and drying them well is that's most effective in my book in terms of trying to reduce the spread of the virus, and obviously staying home if you're sick and got symptoms. And around vulnerable populations, you may take those extra precautions of using PPE or doing some testing.
So it sounds to me as though they're all pretty standard precautionary things that you would take anyway, regardless of COVID or not, if you were a little bit sickly. And it doesn't sound much different. What would you say about how WHO have changed statistics on wearing masks and things like that? So they first of all said, that masks are very important, and our government were listening to that advice, and then suddenly they changed it and our government are not taking their advice anymore. It's all a bit confusing. How do we know how to go forward with that? What advice do we listen to?
Well, that's a good question. I mean, there's often a range of views when it comes to interpreting epidemiological evidence. And so often you can find evidence that will support both sides of the story. So my approach is to look at, is not, can I find evidence to support my viewpoint, but it's more, if I look for the best evidence. So for example, trials tend to be more convincing than observational studies. And so that's what I was saying before about the trial evidence around masks has been very disappointing. So that's what I would encourage people out there. It's almost like, everyone has to make up their own minds. I mean, I think masks are a relatively, compared to locking down a country, they are a fairly low-cost intervention. Yeah. And I'd recommend that people follow the government's rules on that. But in terms of critiquing the government's approach, I think that the best evidence is, we know that trials are the way to go, and generally they haven't been supportive of wearing masks. And meta-analyses of trials have generally, they're considered the top level evidence. So if you are looking at the evidence, looking at the meta-analyses of trials and seeing where a bunch of trial results are, and taking the average of those, which is what these meta-analyses do, that's how to try and get to the truth, because that's where we're all trying to get to, right?
Exactly. And that's that's the reason I'm just so grateful to have this conversation with you. I first, like I said, I don't have TV, so just scrolling through online at some stage I saw an interview briefly with you, and I don't know what show, he's a morning show, but his name's Jack. and he was interviewing you and asking you questions and not letting you finish. And I was like, oh, what an absolute twit. I wanted to know the answer to that. So I thought, can we just get Dr. Thornley? I wonder if he'd have a chat with me, because I'd love to ask you some really good questions and allow you the opportunity to answer them. So, and because we all just want the truth, we don't know where to go anymore. I mean, we're getting censored online, where you're seeing things disappear. People are, saying one comment and next thing their accounts are gone. And it's just really, where on earth do we go for the truth? So I thought, well, an epidemiologist is as good as anywhere to get information about this whole thing. So do you think that, well, you've kind of briefly said with regard to masks that the government's done a good job there, but or do you think there is a better way? Is it, and again, you said that there's a group of epidemiologists who are advising the government and saying all of the opposite of the other bunch of you guys, which I guess is that the Plan B group, the ones who are not pro-lockdown. Is that what it's about?
Yeah. So we've been arguing for a more moderate approach to COVID. Is what we've, that we're unlikely to be able to eliminate the virus long term. So we have to learn to live with the virus, and we have to consider the economic costs of long-term elimination, long-term border restriction, and that we have to put it in perspective. COVID's just one threat to our health. We have a whole range of other things that we need to also think about. And, that sobering evidence coming from the UK that if you're just myopically focused on COVID, things can go wrong in other areas of the health sector.
Yeah, absolutely. Is that where we're actually getting? I mean, I've heard this, and again, I'd like to dig for truth, and I've heard that we're modelling the UK on the COVID response. Who are we modelling?
It's a good question. I mean, I think that the lockdowns kind of were a bit of a Me Too phenomenon. They started in China and then Italy, and that sort of gave license for almost all other areas of the world to lock down in some shape or form. Sweden kind of bucked the trend. They decided that it wasn't worth doing.
I want to move there.
So they now, it looks like the deaths from COVID are just about over in Sweden, and they don't have to face those questions about long-term border closures or whether they go back to lockdown if they get a few more cases, because they've never gone there.
Yeah, so interesting. I find the whole thing incredibly interesting. Do you think that, and I pretty much can guess what your answer to this will be, but just for people out there who want to know the answer to the vaccination question, coronavirus is a series of viruses. Can they or can they not mutate? And would a vaccination even be relevant by the time it was created to that strain? Like are vaccinations even worth it?
Well, I mean, certainly if they're effective, I believe they are worth it. But, one of the most enlightening conversations I had during this whole saga is with a Canadian vaccinologist who's, his whole life is vaccines. And he was really concerned that the expectations on it, he actually got money to build a vaccine or develop a vaccine from the Canadian government, and he's saying that the timelines are unrealistic. My vaccine is not going to be ready to be helpful in this pandemic. It's going to be over. He was talking about trying to build a sort of more generic coronavirus vaccine. There's the world record in terms of vaccine development, as far as I know, is the mumps virus, which took 4 years, and most take 10. So I think it's been disturbing to me to look at government documents on elimination talking about having a vaccine within 18 months. That just seems unrealistic. And, you know, I think when I brought that up, I was labeled as controversial. To me, it's the least controversial thing I've ever said. I'm just talking to an expert, and that's what he's telling me. And as far as I know, that information is true. And
so why is it that now you know, experts such as yourself coming out and weighing in on the conversation and saying, hey, this really, you know, when we look at all the evidence and the statistics, this doesn't make sense, i.e. vaccinations. Why is it that we're suddenly becoming conspiracy theorists because we're not, you know, flowing along with the narrative that is being pushed? I don't understand.
Yeah, well, I think it's, you know, there has been a very strong sort of unite against COVID, and everyone's got to be on the same page. I could sort of understand that initially when, you know, it looked like a very scary virus, high fatality rates, didn't have a lot of information, but now I think things have moved on. Sorry, I've got a meeting in a few minutes,
Yep,
Natalia, sorry.
that's all right. It's been awesome having your time. Okay, well, just to wrap it up, let's just say, do you think, so you don't think vaccinations are going to be ready in time, or obviously not even safe if they are ready within 18 months? You believe that masks are the lowest form of, you know, I guess if you're going to try and protect yourself, instead of locking everyone down, you're better off just going out in a mask. And then just your basic looking after your sanitizing your hands or washing your hands and just coughing into your arm and all those sorts of really basic things is the way you would.
Yeah, and concentrating on a healthy lifestyle, getting out and about, getting some sunshine, getting your vitamin D levels up, and healthy nutrition. Get rid of the sugary crap and the really refined starchy stuff, which pushes you down the road to diabetes and heart disease, and that has a double whammy with COVID. So yeah, that's really the message, is that we need to protect the vulnerable, do reasonable measures to socially distance, to stop the virus spreading rapidly. But we need to recalibrate the risk from the virus. It's clear it wasn't the virus that we feared initially.
Amazing. Such an awesome conversation. Thank you so much for your time, Dr. Simon Thornley.
Pleasure. Thanks for having me, Natalia.